Good afternoon, everybody, and welcome to this exciting webinar. My name is Moises Agosto, and I'm the Director of Treatment for NMAC, formerly known as the National Minority AIDS Council. And today, Jules and myself are very excited to bring to you Dr. Todd Brown. He is from Johns Hopkins University, and he's going to give us a talk about the challenges for people living with HIV and aging, and the latest information regarding aging and HIV that was presented at CROI and some of the presentations presented at the International AIDS Conference that we just had in July. The purpose for us to invite Dr. Brown is that we think that it is vitally important for advocates that are getting ready to raise and advocate for issues related to aging to be up to speed with information, clinical information about the treatment of people aging with HIV and clinical outcomes, as well as potential comorbidities and other issues that I'm sure you're all familiar with. So at the end, what we're going to do is at the end, we're going to have a session. We're going to start with Jules. He's going to introduce Dr. Brown, and then we're going to have Dr. Brown do his presentation, and it would be great if you start putting the questions in the chat. We have someone monitoring the chat. And then, you know, when we complete that, we will take questions from the chat, and we will take as much as we can take of the questions. So with that, I'm going to pass it to my friend Jules to introduce Dr. Brown.
Thank you, Moises, and hello to everybody. Aging in HIV has, for 15 years, been a problem. It was recognized first as a future problem 15 years ago, and in recent years has become increasingly gaining traction and being increasingly recognized and discussed more as a problem for both elderly people with HIV and the aging population with HIV. So let me introduce our speaker today. Dr. Todd Brown is world-renowned as a leading researcher in metabolics and aging and HIV. He's a professor of medicine and epidemiology in the Division of Endocrinology, Diabetes, and Metabolism at Johns Hopkins University, where he's also the primary endocrine consultant to the Johns Hopkins HIV Clinic. He's a graduate of Columbia University College of Physicians and Surgeons and Johns Hopkins Bloomberg School of Public Medicine. Completed his clinical training at Georgetown University and Johns Hopkins. His research focuses on metabolic, endocrine, and skeletal abnormalities, meaning lipodystrophy included, observed in HIV-infected patients, particularly as related to aging. He's the co-chair of the executive committee of the new MAC's WISE combined cohort and the co-principal investigator of the Baltimore, Washington site. He has served in numerous leadership positions on multiple clinical trials in the ACTG on metabolic, skeletal, and cardiovascular endpoint studies. He has served as chairman of the International Workshop on Aging and HIV, which we started about 12 years ago. And he's also served as chairman and a member of the Science Organizing Committee for the International Workshop on Comorbidities and Adverse Reactions HIV. I don't think you could find a better resume for our talk today than this. So I'll turn it over to you, and thank you very much, Dr. Brown, for speaking.
No, thanks, Jules, for the kind words, and thanks everyone for the invitation to come speak to you today. So I'll be talking about studies that were presented this past year at CROI and also some from IS over the summer, but trying to put those into the larger context of what aging with HIV is all about, what we know from a research standpoint, and what we really need to know. And so, and I'll finish with some challenges that I see for aging people living with HIV from a clinical standpoint. So we get the next slide. So here are my disclosures. Next slide. So, the pandemic has given us some perspective. And so I've been thinking about, mortality and, how I want my life to be the rest of my life. And, I think that this graph sort of captures what the ideal life would look like. And so ideally, we want to, on the y-axis, you have quality of life, physical and cognitive function. And on the x-axis, you have age. And so you want to maximize the time where you have high quality of life, good physical and cognitive function. And so that curve would look like this. So you would go along looking good, feeling good, thinking well, and then you would drop dead at age 103 after having spent time with family and friends. Next slide. The issue that we have with aging is that it doesn't always work like that. And so, we have, generally in middle age, some plateau of our physical and cognitive function, but then things start to decline. And some people it declines fast, and some people it declines more slowly, but there is some decline. Next slide. So it's useful to step back a little bit and ask the question, well, why do we age anyway? So next, click on that. So it's important to think about, well, what's chronologic age? So this obviously is the number of years are on the planet. Biologic age, on the other hand, is wear and tear on the organs and age that we look or feel. So we all know people who are 65, but look like they're 50. And we all know people who are 65 who look like they're 75 or 80. So there's definitely a difference between biologic and chronologic age. And so if you click on that, Jess, I'll show you some cars. So these are some good-looking station wagons, same year, probably early 40s. And same make and model and year, but the one on the left, its biologic age is much lower than the one on the right. And so if you were a car, you'd probably want to be the car on the left. And so if you click again, this brings home the point that the chronologic age is not equal to the biologic age. And so, it's important to think about biologic age and how we could potentially manipulate biologic age so that it doesn't progress as fast. And ideally, our biologic age should be lower than our chronologic age. So next slide. So let's shift gears and talk a little bit about HIV, and I'm sure this audience is well aware of the mortality gap. So this is data from Denmark looking at survival in the Danish population in general, and then in the HIV population in Denmark. And so these are survival curves, and so everyone starts off as living, so that's what you see in the top left, with 1.00. So everyone's alive at baseline at age 50. And if you look at the top line, the solid line, that's the people without HIV. And you can see that about 50% are alive at age 80. So if you follow that top line out, you can draw that where that ends over to about 0.5. So that's 50%. So that's the median mortality is about age 80, maybe a little bit more. And so what you see in the other dotted lines are the people living with HIV in various eras. So 96 to 99, 2000 to 2005, and then 2006 to 2014. And so if you follow those lines over right where it intersects with 0.5, the 0.5 on the y-axis, you can see that the median survival increases in each of these treatment eras, which is great. So this means that people are surviving longer with HIV, which is due to the effectiveness of good antiretroviral therapy and the availability, of course, of good antiretroviral therapy. But at least in this period, which ends at 2014, there still is a gap in the median survival between the people living with HIV and people without. And so we haven't quite closed that gap. And so, but it's important to look at these gaps in people living with HIV. And there are other gaps as well, if you go to the next slide. Before I go to the other gaps, I want to just talk a little bit about the age distribution of people living with HIV and what it's going to look like in the future. So this is from the Netherlands, and it looked at the proportion of people living with HIV at various age levels, and the yellow and then the greens at the top. So those are 50 and older, and yellow is 70 and older. And you can see in 2010, 30% of people were 50 and older, with about 2% being 70 and older. And fast forward that into 2030, and the projected distribution of age, it's about 70% of people with HIV in the Netherlands are expected to be 50 and older, with more than 10% being 70 and older. So what we're seeing just from a demographic standpoint, and this is because, of course, the survival of people with HIV, as we've shown, it has increased so much that we're seeing a graying of the HIV population. So next slide. So let's talk a little bit about the gaps in some of these other measures, and I've been studying physical function quite a bit. And so this is from the multi-center AIDS cohort study, which some of you may be familiar with. This is a study of men who have sex with men in 4 sites in Los Angeles, Pittsburgh, Chicago, and Baltimore, Washington. And we follow men every 6 months, and about half are HIV positive, about half HIV negative. And since about 2007, we've been thinking about frailty and aging. And some of the best ways of looking at this is in a large population is doing these functional performance tests. And they're quite simple, but I think informative. One is gait speed. So you basically set up a course that's 4 meters, just one strip of tape on the ground, and then another strip of tape on the ground 4 meters more distal, and you have the person walk at their usual speed. And so what you see here on the left is gait speed by serostatus by age. And what you see in the top line, which is the people without HIV, the men without HIV, that there's a decrease in gait speed with age, as you would expect, and pretty much seen in all cohorts. But what we showed in this paper was that in the men with HIV, there is also a decrease, but that decrease happens earlier and faster than the men without HIV. We see a similar thing with grip strength. So with grip strength, we use something called a dynamometer. Basically, it's a grip testing device. You just put the thing in your fist and pull it, and it gives a measurement of how strong the person's pulling. Again, grip strength decreases with age, but in the men with HIV, the grip strength started to decrease earlier than the men without HIV and decreased faster. So there's this gap in physical performance. Next slide. One way to try to understand or characterize what the aging process is like and whether there's a person who is aging faster is to look at frailty. And frailty, also we see people walking down the street all the time, and we, consciously or unconsciously sort of look at them and can get a sense of whether they look frail. But it's actually a little bit hard to operationalize. And so this is a definition that was created by Linda Fried, who was at Hopkins, which looks at 5 parameters which are thought to sort of underlie the frailty process in terms of their weight loss, weakness, exhaustion, slowness, and decreased physical activity. And the weakness is the grip strength, and the slowness is the walk speed test. And so what you see is sort of another version of the graph that I showed you in the beginning slides, where you have performance, and this is in this case physical performance, decreasing with normal aging. But then there's a group of people who have accelerated aging, where they have a faster decrease in physical performance, and they pass through an area of frailty before going into disability. And so it's important to identify people who are frail, so you could potentially intervene, or even earlier, people who are destined to become frail, so you can even intervene earlier and try to bend that trajectory. So on the next slide, I'll show you the MAC data. So we've been, as I mentioned, we've been doing this since 2007, the frailty testing. And this shows the proportion of study visits of people in a given age group who are frail. And what you see, pretty comparable between the HIV infected, HIV uninfected, up until about age 50. Then something else happens at age 50, where you see that the prevalence of frailty is higher in the men with HIV compared to those without. And that persists through all these age groups. So data in the MACs would suggest that frailty is more common in the men with HIV compared to those without. And this has been seen in other cohorts around the world. Next paragraph. Slide. So what's underlying the physical frailty? And so this is a complicated diagram, but it's useful to sort of think about, what the underlying causes may be. So on the right, you see the clinical aspects, and those are the 5 characteristics that I just talked about. But on the left, you start to see some of these other factors which may be important. And so the molecular and disease, so this is, oxidative stress. So our body makes free radicals as part of the normal processes, but these free radicals can cause damage. And that's thought to be a major mechanism of damage with aging. Mitochondria are energy producing organelles in our cells. And you can get mitochondrial dysfunction in various organs and skeletal muscle and heart muscle, for example, that may lead to problems. And the mitochondria are also affected by things like inflammation, which we'll be talking a lot about, as well as some antiretroviral therapies. Shortened telomeres. So telomeres are on the ends of chromosomes. They're sort of like heard described as the caps on the end of shoelaces to prevent, if you go back to the previous slide, the caps on the end of shoelaces to prevent them from unwinding. So these telomeres get shortened with each division of the cell, and if they get too short, then the DNA is open for damage, is more susceptible to damage. So that leads to the next thing, which is DNA damage, which may play a role, and cellular senescence. So after cells divide, they become sort of age themselves and senescent, and immune cells, for example, when they become senescent, start kicking out all these inflammatory mediators, which we'll be talking about in a second. So these processes are thought to drive inflammation and regular aging, and also neuroendocrine dysregulation. So I'm an endocrinologist, I'm a hormone doctor, and so I think a lot about the thing is in the middle with various dysregulations of hormonal axes, like growth hormone and glucose problems and adrenal problems and testosterone problems for men. And those tend to lead to some of these other things like sarcopenia, which is low muscle mass, osteopenia and osteoporosis, and some of the other things that go along with it, including immune dysfunction and cognitive problems and clotting and problems in glucose metabolism. And so, it's charted here with boxes with arrows, with one leading to another, which leads to another. But clearly, this is sort of a recursive process where you have some dysregulation, and then that causes more dysregulation at a molecular level. And so this is what's been so challenging in trying to understand the process of aging, is that all these things are happening at the same time, and it's hard to tease apart cause and effect. Next slide. So there's some things that, that slide that I just showed you was from a, general aging kind of study, but there's some things that are unique to people with HIV. So when you start people on antiretroviral therapy, the viral load becomes undetectable, which is great. And this is the goal of therapy. However, the virus is still hiding out. And there is there's persistent inflammation, even though the viral load is detectable. And so that persistent HIV and so low-level replication may be driving some of the inflammation that you see in people with HIV. So that's sort of a unique thing. The other thing that happens is microbial translocation. So very quickly after HIV infection, immune cells in the gut are quickly depleted, and you get this so-called leaky gut. And you can, with the leaky gut, you get bacterial byproducts, fungal byproducts, which come across the gut, which lead to increased inflammation. And that also is thought to be a source of inflammation among people with HIV. And then we have co-infections. And so, people with HIV are more likely to have other co-infections, some of which are chronic. And so one of them we have a great treatment for. So hepatitis C, for example, which was difficult to treat, as recent as 5 or 6 years ago. Now we have a medication that can be given, or a combination of medications can be given for 8 or 12 weeks that result in a cure in 95% of people. And so these are very effective ways of decreasing the effect of hepatitis C on inflammation in people who are co-infected. There's another infection called CMV, or cytomegalovirus, which is also a chronic infection, and which our immune system, if you have CMV, which a lot of people do, your immune system is directed towards sort of suppressing that. And there's going to be an ACTG study to look specifically at a new anti-CMV agent to see if treating and curing CMV infection can decrease some of the systemic inflammation, and then potentially decrease some of the risks for frailty, as we've seen. Next slide. So with aging, this inflammation is thought to be a major mediator, not only of frailty, and I see that at the bottom of the list there, but also other comorbidities like diabetes, like heart disease, like cancer, like cognitive problems. So this inflammation has effects on multiple organ systems. And you go to the next slide. So in people with HIV, what you have is sort of a double whammy, where you not only have the inflammation that's related to aging, but you also have the inflammation that's related to HIV. And this is thought to drive the comorbidities that we see, and we'll be talking about in the next few slides. Next slide. So I'm going to show you some data from CROI and from IAS to sort of underscore these points. So this is data from the Optum database, which is a large database of insured and Medicare recipients that was presented. And this sort of gives you a scope of the burden of comorbidities in people with HIV versus not. And so this is about 20,000 people with HIV who were matched to 2-to-1 to people without HIV. And you can see the distribution there of the age, relatively few females, and we'll be talking about comorbidities in women, which is understudied compared to men. But if you add up the comorbidities, and you can see that in table 1 there. So one thing is a comorbidity index score. So this is a way to quantify the comorbidities. They're higher in people with HIV. But if you count up the number of various problems that people have, and you can see those problems in figure 1, just counting those up, the people with HIV have a higher comorbidity burden compared to the people without HIV. And you can see more specifically in figure 1, number of 3 or more comorbidities, 37% in the people with HIV, 31% people without HIV, and pretty much all of these comorbidities are higher in people with HIV compared to those without. There's some exceptions that are worth pointing out. One is overweight and obesity, and we'll talk a little bit about that. It's about the same, although we have some medications now that have been associated with weight gain, and so this is a very hot area, which we'll talk about in a second, a hot area of study and to understand the impact of that weight gain. And then diabetes, this isn't adjusted for body mass index. So we've shown, say, in the multi-center AIDS cohort study, that after the people with HIV are developing diabetes with less adiposity, so at a lower body mass index. And so after you adjust, my suspicion is if you could adjust these data statistically, you would either see the same prevalence of diabetes in the positives versus the negatives, or even higher prevalence in the positives. Next slide. And so this is just the take-home message that comorbidities are higher among the people living with HIV. There's another nice study that it was a modeling study, sort of looking out into the future, into 2030, to understand in various age strata what the comorbidity burden is going to look like. And so this is similar to the data from the Netherlands that I showed you before, but this is data from the US. And so what you see in these various graphs are the number of ART users at age 50 to 60, 60 to 70, and over 70. And just looking at the red, which is 2 or more of these types of comorbidities, it's going to, for the 50 to 60s are going to increase and then level off. The 60 to 70s are really steady increase in the comorbidity burden, and also in 70 and older, a big increase in the comorbidity burden. So this is going to be really important as we move forward into the next, into the next 10 years, trying to figure out how to deal with these comorbidities. How do we minimize the risk of these comorbidities and get people screened and appropriately treated? Next slide. So this is a busy slide, but it's useful going through. It's the same study, but looking specifically at sort of which comorbidities are going up, which comorbidities are going down. And so on the bottom, if you squint your eyes, you can see that these are various populations. So you can see MSM Black, MSM White, MSM Hispanic, then you have the heterosexuals, injection drug users, heterosexual men, and then various combinations. And so the ones that are circled in blue are comorbidities that are increasing by and large, are expected, I should say, to increase in the next 10 years. And so these are anxiety up by 11%. You can see that in the plus 0.113, that's 11%. Depression up 2%. Chronic kidney disease 9%, diabetes up 8%. So these are big increases in these specific comorbidities, and myocardial infarction up about 6%. And you can see there's variation depending on which population is being examined, what that increase is going to be. The hyperlipidemia and hypertension are expected actually to decrease by and large, which is good news. And the cancer depends on the population. So for IDUs, these cancers are expected to increase. So you have a mixed bag of whether or not the various comorbidities are going to increase. A couple take-home messages. One, I think, is that mental health is super important. It's a super important comorbidity related to physical health, obviously. And this is where we're going to be seeing the most changes in the next 10 years. Diabetes and kidney disease, obviously risk factors for multiple other comorbidities, including frailty and heart disease and many others. And then it does depend on which population we're talking about, and there are differences between the populations and potential disparities in access to care and access to treatment and screening. Next slide. So what are the causes of these comorbid diseases? And so you have patient factors, disease factors, and we talked about the effects of systemic inflammation even when the viral load is undetectable. And you have medication factors. And so we know that antiretroviral therapy has gotten much better. It's gotten much easier to take, gone from 25 pills down to, for many people, 1 pill once a day. But there are potential problems with medications as well. So next slide. So fortunately, the medications have gotten better, and I think of these in terms of current effects or effects that are ongoing when someone's exposed to them. And so the one that from a bone and kidney perspective is TDF, tenofovir disoproxil fumarate. This drug is one of the most widely used around the world. It's there has been in the last 4 years or so a movement from TDF to the new tenofovir TAF, tenofovir alafenamide, which has fewer problems regarding bone and kidney disease. But it still is an issue around the world. PIs, again, PIs have fewer or become more metabolically friendly with the most recent PIs, but there's still issues with their increasing cholesterol. Then one thing that we see a lot in the MACs among the men with HIV are these legacy effects. So a lot of the guys in the MACs who have been infected since the 80s got on therapies, when they became available, and were on stavudine or D4T, Zerit, which is a good antiretroviral therapy. No question that it decreases viral load, but it has effects. It has effects on fat in particular and on mitochondria, and it can cause lipoatrophy when even after many years off of stavudine, the fat doesn't come back, and these legacy effects persist. And so we see that prior use of stavudine comes out as a risk factor for a lot of our studies, even now in 2020. And if you click. The other medication that I alluded to earlier that we've been talking a lot about at various meetings is the effect of integrase inhibitors. So integrase inhibitors are good drugs. They're generally well tolerated. They decrease viral load. They have a low, very high barrier to resistance. But there's emerging evidence that integrase inhibitors also lead to weight gain, and lots of studies in the last several years about this issue of weight gain and what it really means and what are the consequences of that weight gain. So I'll show you a few studies from CROI about this. Next slide. So this happens around the world. And so this is a study from Kenya looking at people initiating the integrase inhibitor dolutegravir versus an NNRTI. And what you see here is it stratified by sex, males and females, and those who started the NNRTI are in blue, so generally efavirenz. And those who started the integrase inhibitor dolutegravir are in either the salmon color or the orangey color. And what you see is that the weight gain, weight increases with antiretroviral therapy, but the weight gain is more in those who were given dolutegravir. And we've seen this in randomized trials. We've seen this in all kinds of different settings. And one of the big questions, well, is it weight gain? Is it a return to health phenomenon? So are these people underweight to begin with and they're just getting better with antiretroviral therapy? Or is this really something pathologic? And I think there is a return to health phenomenon, but we also see this weight gain at people who are normal weight or even overweight who initiate antiretroviral therapy. We also see this effect with integrase inhibitors when you switch from a regimen that's working, say a PI or a efavirenz, onto integrase inhibitors. And there's some evidence, and I don't have time to go into it, that the drug that either the comparator drug, if you're talking about a trial with initiation, or the drug that you're switching from that's important. So the weight gain that you see if in the switch study, for example, is much more from efavirenz to an integrase inhibitor compared to a PI to an integrase inhibitor. So some of the effect that we see actually may be related to the regimen that people were on and switching off of them. Similarly, there's an issue or emerging issue with TDF and TAF, where if you just make that switch, you do see an increase in weight. And this also leads to the question of whether there's some appetite suppressant effect of TDF that you're taking away when you switch, or is it some appetite inducing or fat gaining kind of effect that you see with the TAF? And we haven't quite figured that out yet. Next slide. So one of the critical issues is, well, what about with this weight gain? Does it cause problems? Does it cause any ill toward effects? And one of the close correlates of weight gain is diabetes. And this study that was from a observational database, a large kind of claims kind of database that Jane O'Halloran presented, really is one of the first studies to show that the initiation with integrase inhibitors was associated with about a 22% increased risk of diabetes. And the effect was greatest with dolutegravir, as you see. There wasn't enough bictegravir to really look at that specifically. There were some adjustments. There's some, warts on the study, and there's warts on all studies. But in general, I think that the message here is really important, that this weight gain may be clinically important and may lead to weight-related complications like diabetes. Next slide. The other important issue with weight is sort of where is that weight going? And so this is, this slide I got from an article that had nothing to do with HIV. So we do get body fat changes as we age. So we get increased fat in the belly, so-called visceral fat, lower subcutaneous fat, so fat underneath the skin. And then you get an increased deposition of ectopic fat. So this is fat not in normal depot. So this is fat in the liver. This is fat in the pancreas, in the muscle, and in and around the heart. And so one of the outstanding questions here regarding integrase inhibitors and TAF as well is whether the weight gain that you see is also affecting ectopic sites, and is that affecting organ function? And so this is something an area of interest, and I think in the next few years we'll be seeing more data about this. Next slide. So again, the causes of comorbid disease in HIV, again, an interaction between these various factors. Next slide. So when you look at the patient factors, it's useful to split them into modifiable risk factors, like age and sex and your genes, which you can't do much about, versus the modifiable risk factors. And these are all factors on the right that you can do something about, you can modify. And so importantly, when we think about contribution to comorbidities, you think about weight, as we talked about, smoking, alcohol, exercise, dietary patterns, and adherence to antiretroviral therapy. Next slide. So chief among these really is smoking. Smoking is bad. It's bad for lots of things. And so, generally, if someone who smokes, quitting smoking is the single most important intervention you can do for long-term health. Next slide. And this is really shown well in this NA-Accord study, which was presented at CROI 3 years ago, maybe, and then in Lancet HIV a couple of years ago, where they tried to look at various risk factors in NA-Accord. So NA-Accord, for those you don't know, is a cohort of cohorts. It includes our study, the MAX-Wise combined cohort study, but it's about 120,000 people. And so they looked at heart attacks and tried to understand what is what they call population attributable fraction for all of these risk factors. Meaning, if you were to take away this risk factor, what kind of reduction would you see in the risk of the outcome, in this case, heart attack? And the ones that are most important are the traditional risk factors and total cholesterol, hypertension, and of course smoking. So this tells us that the traditional risk factors are really important among the people with HIV. And you can see other things like hepatitis C infection, low CD4 cell count. Those are important factors, but nowhere near what these traditional risk factors are contributing to the risk of MI. Next slide. So we see these kind of various risk factors that are important with cognitive decline as well. And so this was a study from the Charter cohort, that's been going on for a long time at various sites, including Johns Hopkins, and looked at cognitive decline over, I believe it was a 15-year period, and what are the factors that are associated with cognitive decline. And so it turns out that some of these comorbidities that we see, in particular chronic lung disease and diabetes and hypertension, were the main drivers of a decrease in cognitive function over this time period. And interesting, I want to draw your attention to the third graph there, and as a diabetes and major depressive disorder. So you see that people with diabetes are more likely to have a decrease in cognitive function over this time period, but you really see it in the people who have both diabetes and depression. And so, I think that that's a major theme here, is the interaction between mental health and physical health and the effect on outcomes like cognitive decline. So, I think that from thinking about, people's health overall as they age, is not only that they have comorbidities, but these interactions between physical health and mental health are really important. Next slide. So I want to throw in something about COVID, because I think it's important, and these are important data, and we're living it now, obviously. But this is done through a giant cohort, academic medical centers collecting data about people who had COVID-19, and this looked at the hospitalization rate in people with HIV. And without HIV, those who've had a solid organ transplant, that's what SOT stands for, and those who did not. So, people who've had a transplanted organ are also on immunosuppressive drugs. So this study was comparing these types of immunosuppression. And what you see is that for both HIV and people who've had transplants, the risk of hospitalization was, 2 to 4 times higher in the crude compared to those without either of those things. And then when you adjust for various things in statistical models, you still see about a higher risk of hospitalization among people with HIV. So this underscores the fact that people with HIV are at risk for more severe COVID. Now, the other important thing, that's important in and of itself and has implications for booster shots and things that we're thinking about now. But the other thing that we don't know, and thinking about this long term, even after the pandemic subsides, is the issue of long COVID, and whether about 30% of people who've had COVID have persistent symptoms afterwards, even 6 to 12 months afterwards, and trying to understand whether or not long COVID is different in people with HIV, or more severe, or differently characterized. So I think that that's an important question going forward. Next slide. The other thing to think about, this is looking at, with the same data set, looking at interactions between HIV and various comorbidities. Like we see in the general population, those people who have heart and lung comorbidities, in this case, those who've had a heart attack in the past, those who've had congestive heart failure, who've had stroke, those who had kidney disease and pulmonary disease, are at higher risk of hospitalizations for COVID outcomes. So you get this, that you have a comorbidity plus HIV, makes COVID worse. Next slide. So I want to shift gears and talk a little bit about comorbidities in women with HIV, because I think this is an important topic, and there's some recent data about it. So next slide. So this is data from the MaxWise combined cohort study that I work in that was presented by Lauren Collins. And again, sort of counting up the number of comorbidities. And so sort of a busy data, but it's worth walking through. And so what you see is that with these various shades of blue are the number of comorbidities. So non-AIDS comorbidities and NACMs. And so what you see is that with increasing age, the blue bars get darker. Blue bars get darker as you get older, right? And then blue bars are darker among the women compared to the men. And then if you look in the HIV versus not, the blue bars are darker in those who have HIV. And the graphic representation is given on the right here. So you have the estimated number of comorbidities in people with HIV, women with men. You can see that among the people with HIV, the women have slightly more comorbidities by age compared to the men. Not statistically so. In the HIV negative, again, women have more comorbidities than men. But what's important here, the comorbidities increase with age, as we know. But the difference between the age progression with these comorbidities by HIV status is more pronounced among the women compared to the men. And so this is an important observation, I think. So the burden of comorbidities is higher among women, and the difference by HIV status is greater in the women than the men. So women are really important when we're thinking about these comorbidities, and how do we specifically target women for the screening and treatment of these comorbidities. Next slide. And this study, this was from the Optum database that I showed you before from CROI. They had a study at IS, basically showing the same thing. A larger data set, it's always good to have confirmatory data, but again, more comorbidities, more multimorbidity in people with HIV compared to those without, and that the differences by serostatus were greater among the women compared to the men. Next slide. This study at CROI started to think about, well, why might it be that women are more likely to have comorbidities? We talked about inflammation being a major driver of these comorbidities. Is inflammation higher in women compared to men? And so that's what this study looked at, and that's what the graph on the left is. And you can see that in red, you can see that all these alphabet soup things, these are all inflammatory markers. And they compared the difference in the men compared to the women. And what you see is that all of these markers are, except for say IL-18 and to a lesser extent that STNFR1, which is a TNF receptor, all of these markers are higher in women compared to men. And then they looked at, well, how do these markers relate to various end organ problems? And so they had a composite event of heart attack and death. And what you see is that you can see the red is the women, the blue is the men, and the red bars are a little bit further right compared to the blue bars, suggesting that the effects of these are stronger in the women compared to the men. So not only do they have higher levels of inflammation, that inflammation may have a greater impact on end organ events. Next slide. So I've shown you these, that sort of smooth curve of how physical and cognitive function may decline over time. But in reality, it might not be so smooth. So next slide. So it could be, and if you just click on through that, and there are a bunch of, so you have a person who is pretty good, up until about age 50, and something happens. They have a heart attack, and they drop in their physical and cognitive function as they're recovering and never quite recover. And then something else happens. They develop heart failure. Again, they drop in their physical and cognitive function, but never recover. Again, something else happens, a hip fracture, for example, they have a big drop in their function and don't recover, and then something else, stroke, and they're down into the disabled status. So these events tend to precipitate drops in cognitive and physical function and quality of life. So while we may model these things as sort of a smooth curve, in reality, they're really quite disjointed. So next slide. So if you click through these, so part of this with the comorbid disease is trying to prevent these things from happening, prevent these events from happening such that you never get that drop in physical and cognitive function. And so there are a few important points here. So for many things, good screening tests are available for comorbid conditions, say diabetes or dyslipidemia or hypertension. And there are behavioral factors that contribute to comorbid conditions that can be modified. So things like smoking and weight, for example. Early treatment is really important. So finding the disease and starting people on treatment early, say for diabetes or hypertension. And we have good treatments now for lots of things that can decrease the risk of events, whether it be cardiovascular disease, focusing on diabetes management, blood pressure management, lipid management, or fracture, figuring out if someone has osteoporosis and getting on an osteoporosis medication if appropriate. And click again. And really preventing complications of these things, identifying and then preventing these events really can alter the aging process. So I think that that's a really important take-home message. Next slide. So this gets back to what Ben Franklin had told us, many years ago, which we didn't really adopt in our healthcare system, and that an ounce of prevention is worth a pound of cure. So we're really good at dealing with disease once it's already manifested itself. So treating cancer, we're pretty good at, and we're getting better with good therapies. Treating all kinds of things when they develop. But what we're not very good at, and what our healthcare is not geared towards, is trying to prevent some of these diseases in the first place. Next slide. So one important thing is getting screened for various things, and you can see a whole bunch of conditions here on the left, and tests that can be used that are quite simple to identify these conditions and how often people should get them. And so I think that patients should know what screening tests they should be getting, and doctors really are generally quite good about trying to get some of these tests. The problem that you get into with older people is that there's so much to do and so little time in an appointment slot that you need to prioritize, and some things sort of get on the back burner and don't come off the back burner. So for example, with DEXA scans, so bone is one of my big areas, and it's really tough to get people to get their DEXA scans, even though it's recommended in men with HIV over 50 or all postmenopausal women. But it's just, you have to write the order, the provider has to write the order, the person has to go, the person has to want to go. So there's lots of different steps that need to happen in order for that screening to occur. Next slide. So we think a lot about, when we think about HIV, this HIV treatment cascade. And so you have a certain number of people who are HIV infected, and then you have those who are diagnosed. There are some who are not diagnosed, and then you have those who are linked to care, those who are retained in care, those who get on antiretroviral therapy, those who remain suppressed. And we're trying to close those gaps and in the cascade, and identify where the problems are. And so, next slide. We also have treatment cascades for comorbidities. And so this, I actually made these numbers up completely, so don't cite them. But just for illustration purposes, you have a group of people who are at high fracture risk. And then you have a group of people who that's less, that's identified as having high fracture risk. So they've gotten their DEXA scan. And of those who are identified as high fracture risk, a smaller proportion who are prescribed for specific treatment, and then a smaller proportion who remain on that specific treatment over time. And so try again with all of these comorbidities, seeing where there are gaps in care and trying to understand where those gaps are, trying to identify the barriers, decrease the barriers, I think is really critical. Next slide. Just a few words about inflammation. I've been talking a lot about inflammation and different approaches to decreasing inflammation. And there have been, through the clinical trial group and other places, an effort to try to focus on different aspects of inflammation. And just a few different things to talk about. As far as chronic antigen stimulation, these co-infections, so I mentioned about HCV treatment. And CMV treatment as a potential emerging therapy. And there's a Lamotrigine trial that's going to be happening in the ACTG. So that's a potential way to decrease immune activation. Microbial translocation, so trying to decrease the leaky gut. And there's been various strategies. Actually, none of them super effective. There's been trials in the ACTG about probiotics, about rifamycin, sevelamer, and they all have been a little disappointing actually in whether you can decrease inflammation by trying to focus on microbial translocation. There are potential ways to boost immune recovery, and then anti-inflammatory agents. And the one that's is most commonly being used are statins. And so statins are good drugs to decrease LDL cholesterol, decrease the risk of MI, but they also decrease inflammation. So whether statins can have effects in people with HIV to decrease inflammation, to improve some of these other outcomes is a really important question, and one that's being actively studied in a study called REPRIEVE, which some of you may be aware of. So this is the largest study, actually randomized study that has ever been done in HIV, about 7,800 people around the world randomized to pitavastatin or placebo. And we're fully enrolled and following people. I'm involved in a sub-study looking at muscle function in the study, and also part of the Baltimore site. And so fortunately with these randomized trials, of course, it takes some time to get the right answer, but we'll be seeing more data about that coming up in the next several years. Next slide. And so the other big picture question is, well, you have these underlying molecular mechanisms related to aging, and this isn't specific to HIV, but can you intervene on some of these hallmarks of aging? And you can look around this here and see some of the things that we talked about regarding senescent cells and damaged DNA and epigenetic changes, which are changes to the DNA, telomeres, protein folding. So all of these are being investigated as potential strategies to try to get at the underlying mechanisms of aging. And some of these are being tested in people with HIV. There's a lot of interest in looking at senescent cells, for example, in people with HIV and trying to do therapies to clear those senescent cells. Next slide. So I showed you this graph before. You have normal aging and a group of people who's accelerated aging. So one question is, well, where do you intervene? If you do a couple clicks. So you can intervene really for primary prevention before you become frail. And these are generally applied to a larger population, and they're low cost, low toxicity kinds of things, emphasizing disease reduction behaviors like smoking, nutrition, exercise, screening, and controlling comorbid disease. So that probably gives you the most bang for the buck. There's also secondary prevention, and these would be interventions that similar to the ones that I showed you in the previous slide. They're important, but are going to be more expensive, and will probably have more toxicity. So I think they have a place, but it's much more important, in my view, to focus on primary prevention for this. So focus on the things that we know work and try to implement them in the best way possible. Next slide. So talking about inflammation, and I give talks for patient groups in NATAP, and this is a slide that I always include. You know, people are wondering, well, how do I beat, what's this inflammation thing all about, and how do I beat it? And you know, I always think about inflammation. You know, we all get splinters every now and again, and when you get a splinter, say in your finger, it's covered with you know, it becomes red, it becomes a little swollen, a little bit tender, and this is your immune system reacting to this foreign body that's in your finger. And so this inflammation happens elsewhere in the body. It happens in the fat, happens in the liver, happens in the lining of the arteries. And so how can we decrease this? And so importantly, staying on HIV medications, staying undetectable, stopping smoking, maintaining normal weight, decreasing weight if someone is overweight, exercising, healthy diet, cutting down on alcohol and avoiding drugs, curing the hepatitis C. Dental health really is quite important, and systemic inflammation. So all of these sort of simple things, preventive measures, can actually have, you know, quite an impact on inflammation. Next slide. So I've talked a lot about comorbidities and talked a lot about physical frailty, but there are other sorts of frailty that are also important and are also interact with physical frailty and also cognitive frailty. So this is sensory frailty, for example. So hearing goes with age, decreases with age, but it's reversible. So you can get hearing aids and it can actually improve people's quality of life. Or vision, for example. So I have these readers, and my quality of life is much better when I have my readers on. So trying to identify these sensory problems and treat them, I think, is really important. And then the ones on the right are super important and interact with the others. And this is social frailty, so people's network and loneliness and some of the issues that come with that, and also mental health and emotional frailty as well. Next slide. So when we talk about a geriatric model, it's useful to treat the whole patient. And so on the left, you see, you know, biomedical inputs here into HIV and comorbidities and prevention. And on top, you have psychosocial inputs, which are really important in terms of some of these social issues, existential issues, psychiatric issues, practical issues, excuse me, like food insecurity and stable housing, and then education being important. So it's important to take a broad view of the patient, which is difficult, actually, the way our healthcare is set up. Next slide. So there were a couple studies at IAS that I thought were really interesting to sort of get at this question of some of these other contributors to physical problems. And so this one looked at a handful, about 50 people with HIV, all with undetectable viral load, and looked at measures of psychologic stress and did PET scanning, which measures metabolic activity in the brain and also in the carotid arteries. In the carotid arteries, it's a measure of inflammation. And so what you see here is that their measure of psychologic stress was associated with less of metabolic activity in some of the key brain areas related to emotion. And these are the amygdala and the hippocampus, important parts of the limbic system. Also, higher levels, and this is the bottom graph, higher levels of psychologic stress were associated with increased carotid inflammation, so inflammation in the carotid artery. So again, this is this interaction with the physical health and the mental health, which I think is really key. Next slide. Another sort of unrecognized potential contributor to various physical health problems is sleep. So we all sleep, and you know, some people have good sleep, some people have bad sleep. It of course is very variable depending on what's going on. But what this study looked at is a Alzheimer's disease related protein measured in the cerebral spinal fluid, which surrounds the brain and the spinal cord. And so basically you clear this protein with sleep, and if you don't sleep enough, this protein sort of stays in the brain and is thought to contribute to the pathogenesis of Alzheimer's disease. And so lower levels in the cerebral spinal fluid are a bad thing. And so what you see here is in a small pilot study is that the worse sleep people get, and this is by this measurement called the vCROI, this is a self-reported kind of thing, they had lower levels of this protein, suggesting that they weren't clearing this protein well from the brain. So again, interactions between sleep and cognition and potentially other bad things down the road. Next slide. So another source of stress that we see is, which is particularly true among certain populations of people with HIV, is sexual minority stress. And so here they quantified this sexual minority stress, and they looked at something called the epigenetic clock. And so you can tell by different ways that the DNA is modified, whether or not it's associated, what sort of the biologic aging is all about. So this is something called the epigenetic clock, and it's been suggested that this is a good marker of biologic aging. And so what this study showed us is that the more sexual minority stress this group of MSM, about 50 MSM had, the greater their biologic aging. So you can't confirm cause and effect here. This is a cross-sectional study. But what it does suggest is that there may be other inputs we need to be looking at the whole picture here. There may be other inputs into aging than some of the stuff we've been talking about before. Next slide. So if you just click through the bullets there, I just wanted to recap some of the key questions. So are the mechanisms underlying aging same or different in people with HIV compared to the general population? I think that question is key. How much is the accelerated functional decline in the older people with HIV related to unique factors in the first wave of this population? So we had a bunch of people, and this is what we see in many of the men in the multi-center AIDS cohort study who were infected in the early 80s. You made it until the mid 90s when they were able to get on good antiretroviral therapy. During that time, they were exposed to various antiretroviral therapies, some of them more toxic than others. They had uncontrolled viremia for a long time. They had low CD4 cell counts generally when they initiated antiretroviral therapy, and there's sort of legacy effects of those problems early on. So if we had two people who are 65, one who's been infected since the 80s and a long history of uncontrolled viremia, been on lots of different antiretroviral therapies, and you have another person who just was infected, in 2015 and started on one tablet once a day regimen at a high CD4 cell count. Are the aging trajectories going to be different in those kinds of people? And that we just don't know. There are just so relatively few people in that latter category who are in their 60s and 70s at this point. So the other point is, can we use the implementation science, or trying to understand, identify that things work and how to identify the barriers or why those things aren't implemented to optimize this comorbidity cascade that I showed you with the example of fracture? And what really are the best management strategies to optimize healthy aging in people with HIV? Next slide. So I just put a list of some of the things that I think are major challenges. That was the title of the talk anyway. Major challenges for aging people with HIV. So I think we talked a lot about multimorbidity. One issue is really, what's the best model of care? Should the person who takes care of their HIV also be their internist, to be their primary care physician? What's the role of a subspecialist? So I'm an endocrinologist. So What's my role in the care team? What's the communication between the team? Is there good access to geriatric care, which generally takes a holistic approach, but is quite expensive, and there needs to be resources set up for that. Healthcare navigation, as we get older, and problems get more and more complicated, it becomes increasingly difficult to navigate the healthcare system, making appointments, trying to figure out who to go to, trying to help make treatment decisions. How can we help older people with HIV navigate through the healthcare system? Mental health services, I mentioned multiple times, but I think is really, really critical. And in many places, including Johns Hopkins, it's difficult to get good mental health services. Social services, trying to focus on some of these other issues, say food insecurity or unstable housing, which are really critical. Prevention of disability is important. Long-term care, I think, as the HIV population gets into the 70s, 80s, and beyond, we're going to need to train long-term care facilities. That HIV is a treatable disease. There's probably a lot of bias there, just because they're not used to having as many people with HIV as are coming down the pike. And then I think health disparities are really important. There's clearly disparities by race, sexual minority disparities. I think those need to be identified and addressed. And next slide. So I showed you this curve where we have a function, decline in cognitive physical function over time. And next slide. And I think that trying to address all these things, trying to address the physical comorbidities, preventing those events from happening, addressing mental health, trying to deal with some of the stress is really the way to bend that curve upwards, so that people can age healthier. And I think that's the end, and I'd be happy to take any questions.
Great. Thank you for such a comprehensive and very excellent presentation. And we're going to go to the questions in the chat, but I wanted to start with a question myself, right? I'm one of those that I was diagnosed in the 80s, and the whole story that And but it was interesting when I passed my 50s. I was in a point that HIV was kind of easy to manage, right? In terms of the treatments, the visit to the doctors. But then after my 50s, what I found funny at the moment, but I got kind of concerned, was that everything started to be complicated again. I mean, went to the doctor, the cardiologist, and I had to take this and I had to take that. And suddenly I found myself also with a bunch of pills and, having to go to more appointments that I used to be in that small period of time between 40s and 50s. And, and then also I realized that, in the early days, it was so important as a patient to be informed and educated about all the things that entitle HIV care. Like, for example, that I had to take my Bactrim and Dapsone to prevent pneumonia, that I had to take my fluconazole because suddenly I had thrush in my esophagus. So it was a lot of maintenance work that you had to team up with your doctor. There was a lot of information to handle. And I find, and when I hear you and when I see, the things that we need to do now moving forward is very similar to that kind of, on hands, let's team up and get educated, because the system, I think, is it's not ready, right? And the question that I wanted to ask you was, I know you work with those systems, and in the work that we want to do in this working group also has to do with the advocacy that we need to do to make sure the systems are prepared to what's coming or what is already here. So what is your take about that? And
so I hear you, and what made it seems, things simple for more simple, maybe, if you had an HIV doc that you knew and trusted, you felt the connection to, that was great, right? And they could deal with all the HIV and stuff. But now you're in a situation where you're getting referred to all kinds of different specialists, right? And it could be that your HIV doc is someone different than does your primary care, and HIV might be just a little bit, one of many problems. And I think so coordination among specialists is really important, I think. And then having specialists who really, think about HIV is really important as well. At Hopkins, we have, I have my own endocrine clinic. I'm not embedded in the HIV clinic, but, people call me up all the time. I probably do as many phone consults, so-called curbside consults. Hey, what should I do with this guy? What should I do with this woman? As I actually see patients, establishing those relationships, among providers is really important, and being able to do those so-called warm handoffs. Hey, this guy, he's here for, the provider calls me up, he's here for his diabetes. What do you think about his regimen? So that kind of communication is really important, but often difficult. And so people's care gets very complicated. And then you mentioned, all the pills that you're getting. It seems like the mid 90s all over again. You have this fistful of pills, and you have to have a pill box to really manage them well. One of the issues going forward is this issue of polypharmacy, and whether people actually need all the medications that they're on, particularly as they get into their 80s and 90s. And so, as specialists, you tend to look at your own, little area of the person, your own expertise, not really taking into account the full person and all these medications that they're on. And so having a internist or primary care doctor who can focus on sort of the big picture. Hey, do you really need to be on that Prilosec? You were on it before. Maybe we can, maybe you can take off and it'll take one pill out of your regimen. Maybe we can combine this. Maybe you don't need to be on that. And so trying to, to think with the patient about trying to de-prescribe and being on the optimal regimen. What is the optimal regimen? And that may change as people get older.
One more thing, and then go to the. We are now looking at could be a good point, right? When we look at early treatment, early screening, but also this is not only for us when we want to build a better system. This is also for those that are young, HIV positive people that are now used to once a day, one pill, undetectable, CD4, that's it. That this is work that needs to happen not only with us, but only with those that are getting closer to those ages. I guess that's a statement more than a question.
Yeah, no, but I completely agree. And they, a lot of people who are infected recently, in the last 10 years, haven't known anything besides the one pill once a day, and don't realize that it is, that healthcare gets sort of complicated and can get complicated later on.
Great.
Go ahead. We do have a couple of questions. We do have a couple of questions in the chat from the audience members.
Yes,
first one being, at what point can a long-term survivor ask for bone density scans? Are there any symptoms for low bone density? Any treatments?
Yep. Yeah, great question. So if you look at we always start with the general population and what are the recommendations for screening in the general population. And so the U.S. National Osteoporosis Foundation recommends that women 65 and older and men 70 and older should get a bone density scan. And so this is a simple scan, takes about 20 minutes, very low dose radiation, about 10 times less than a chest x-ray. And you can get a sense of what a person's fracture risk is and whether they need to go on bone specific medications. And so it's pretty clear from data, over the last 10 years or so that people with HIV have a higher prevalence of osteoporosis or at a higher risk of fracture. And so in the guidelines that I've written, we have said that men 50 and older and women, all postmenopausal women should get a DEXA. So to try to decrease the, age is the biggest driver of fracture, but we should be looking earlier in men and women with HIV and look to see if they need to be on medication. And or if they, other things that they can do to preserve bone health, stopping smoking, stopping heavy drinking, weight-bearing exercise, calcium and vitamin D, et cetera. So, I think that, that is our recommendation. The National Osteoporosis Foundation, I think it was 2015 or so, there's a list of conditions where earlier screening should happen. And back then they finally said, yeah, people with HIV should get screened earlier. And so, one of the issues that come up is, well, will insurance pay for it? And, I've had to wrestle with some insurance companies about, screening a person younger than the real NOF thresholds, but there's a lot of data to suggest that screening is necessary and treatment is effective. And so, medications like, bisphosphonates, reclass, they decrease fracture risk by 40 to 50%. So don't eliminate fracture risk, but really have a big impact.
Great, thank you. The next question that they have is, what is a good BMI for long-term survivors? It seems extremely difficult for me, a long-term survivor, to lose weight.
Yeah, so that's a good question. Is what is the sweet spot? Too low versus too high, and some of it depends on the distribution of the body fat, and some of it depends on not so much fat, but other aspects of body composition like muscle and conditioning as well. So I think that somewhere around, if you look at mortality curves, you have sort of a U-shaped curve. If you look at weight and then and mortality, weight, higher weights, there's more mortality, but also lower weights, there's higher mortality. So the sweet spot is somewhere a BMI between about 24 and 26 or so. For bones, having a little more weight is probably a good thing, but other conditions, having more weight is not so good. And it also depends on underlying fat, like where the fat is, as I had mentioned before, and also someone's underlying genetics. So, I think I wouldn't get too wrapped up in the weight itself, trying to get in, exactly what BMI to get to, but trying to get down to somewhere in the, say, 23 to 26 range would probably be the optimal for health.
Great, thank you. Another question was, physical function assessments may be simple, but most physician practices and HIV clinics are not set up to perform them. How might we increase access to such assessments? Could they be offered by community pharmacies, urgent care centers, at senior centers? Any other ideas? What's being done?
Yeah, so that's a great question. So I'm involved in our frailty working group at Hopkins, and we ask this question all the time. What can we do to improve frailty assessment? Doing the grip strength and walk speed. And so I think all of those ideas are great. Trying to standardize and teach people how to do it. How to do some of these frailty tests to identify people who are frail or who are pre-frail. Yeah, I think that this is where creative implementation is really important. I think the issue with pharmacists is really a good one. I think that the pharmacists are really underutilized health professionals. Oftentimes, in retail pharmacies, they're busy doing other things and may not have time to do it. The other issue, of course, is time and trying to build that into the schedule. But you don't really need. If the person gets trained, and we do this, for our studies, they don't need, once they learn how to do the frailty assessment, you don't need any, real special degree. We have, research assistants doing our frailty assessments, and it's excellent data. So, CMAs, are the people who take your blood pressure in the clinics, they could be trained to do it. It's really a matter of flow in the clinic, and trying to get people in the clinic and out of the clinic. But I think that trying to brainstorm as to what the best strategies are. In a geriatric clinic, they have resources to do that, but the initial geriatric assessment takes a couple hours, and the reason being is that they're in addition to some of these physical function tests, they're doing cognitive functions testing, et cetera. But the big question is how you scale that to a larger population.
All right. So another question is, does peripheral neuropathy increase with age? Isn't it also I think, once again, the question cut off. Isn't also a common morbidity?
Yep. Yeah, definitely. So peripheral neuropathy, so nerve damage, can be caused from multiple sources. So I mentioned the legacy effects of older antiretroviral therapies. One of the legacy effects that I didn't mention is neuropathy from the D drugs. So people who have been exposed to DDI or D4T back in the late 90s, early 2000s, who developed neuropathy may have persistent neuropathy that never really went away. There are other factors that may contribute to neuropathy, diabetes, for example, other various medications, sometimes aging, as was mentioned, in itself can lead to neuropathy. Yeah, but neuropathy is a big problem and can lead to can be painful in and of itself, and so may need specific treatment, say Neurontin for neuropathy. But also on the sensory side, and this is often people who have profound neuropathy, can't feel their feet and can't really feel where their feet are in space, they are more likely to fall. And if they're more likely to fall, they're more likely to have fractures. And so, trying to understand how to treat the neuropathy and how to minimize the risks of having neuropathy is really important.
Great. Another question we have is, since we now know some ARVs cause harmful side effects, should we be prescribing countermeasures when we start someone on those meds? For example, prescribing diet and exercise with TAF.
Oh, yeah, great question. So I think so. Certainly benign treatments. Like if you were to start people on antiretroviral therapy and you know that their weight is going to increase, to say, hey, you might want to, think about your diet and exercise regimen, so we can minimize this bad weight gain. Or you could think of adjunctive therapies. So there's some medications that can be given to decrease weight, and can those medications be given when you make the switch to an integrase inhibitor just for a relatively short period of time, so you can prevent that weight gain from happening. And I think that these are all really important questions regarding this weight gain issue, like what to do about it, or do you switch people off to another regimen that may be less associated with weight gain? So all these questions are being studied actively now. Unfortunately, we don't have the answers right
now. Are probiotics good for gut issues related to HIV?
Yeah, hard to say. There was one probiotic study that was in the ACTG, which really didn't show, didn't reach its endpoint, so it didn't seem to be all that useful. I think we just don't know a lot about how best to intervene on the microbiome. We think the microbiome is important. The microbiome is the community of bacteria that are in the gut, good bacteria and bad bacteria, and diversity of bacteria. We think they're important in chronic disease, not only in HIV but in the general population. But how you intervene on that and whether probiotics are a good intervention really hasn't been determined. It's a very hot topic, though, in trying to figure this out.
when will we have something to help us with weight when we gain from HIV medications?
When will we have something? Is that the?
Yes, I guess their question is asking, is there a discussion around medications that can help people with living with HIV that are gaining weight from their HIV
Yeah, I
medications?
mean,
Like, is there
we're
anything in
having
discussion?
improved success with weight loss agents. And so there's a diabetes medication, a class of medications called GLP-1 receptor agonists that also have a decreased sugar, but also decreased weight quite profoundly. And those are a few of those drugs are approved for obesity, and have been used for that purpose. The problem is really getting third-party payers to pay for it. So I think that there's going to be more and more data regarding these drugs because they seem to have an effect also on liver fat. And then there's some combined agents working on gut hormones that affect weight and affect glucose metabolism that have very even greater effects on weight. So I think that in the next 5 or 10 years, we're really going to be seeing more of these more effective weight agents.
Great. There's very little info and discussion of diet and nutrition for older people living with HIV, especially for those living on limited low income, the majority. How do we as community advocates change that?
Yeah, I think that that's a critical question. So you have the issue of what people should be eating, and then and how they should be preparing it, and whether or not they're able to find these foods and able to afford them. So I think it's a multifactorial kind of thing, but I think education is clearly important. Trying to figure out, we like, a patient once told me, she tries to avoid, any foods in boxes and cans, which I thought was a good way of describing it. We try to get, fresh fruits and vegetables if we can, but sometimes it's hard to find them. And if you do find them, sometimes they're expensive. And so trying to figure out strategies to get healthy food and strategies to help people prepare healthy food, I think is really important.
Great. This is a really good question. There's a national shortage of HIV specialists, geriatricians, mental health providers, and with experience treating older people living with color and LGBT+. Is Johns Hopkins University or other centers of excellence providing such consult services via telemedicine to expand access?
Yeah, and I think it's really important, these kinds of services. We're sort of in a period now with telehealth that I think it was precipitated by the pandemic, where telehealth was necessitated, and it actually works pretty decently. Part of the issue, so I'm not sure on the psychiatry standpoint if they're expanding their services and offering telehealth. I think it's a great idea and really important. Part of the issue that you get into with telehealth is state licensure, where you're only licensed in the states that you're licensed in. And during the pandemic, in the early parts of the pandemic, they waived all these and had reciprocity agreements with states, so that as a Maryland provider, I could see a patient in New Jersey or anywhere really, and I could bill for it and everything like that. But all these agreements have since expired. And so trying to figure out, so seeing a patient across state lines has become difficult again. And so trying to figure out, as a whole healthcare system, where does telehealth fit in? How can we use this technology, which works decently well, to provide more care for more people, I think is really critical. And how people have access to a platform where they can do the telehealth visit, and how can providers get reimbursed for it.
Great. A question that someone had is, what is sexual minority stress?
Yeah. So this is like, I'm not an expert in the area, but internalized homophobia is another, a dimension on that scale. So this is mostly related to, in this case, men who have sex with men, and how people feel about their sexuality. And so there are scales, validated scales that have been developed to understand this level of stress, and some of the issues that have people carry with them, if perceiving that stress, and that and oftentimes it's a lifetime exposure, particularly older people where the society was less accepting.
Okay. Any sense of why mental health is such a challenging issue? Is it a workforce issue? I guess kind of talking about
Yeah.
the hospitals or areas around that.
Yeah, I think it's multifactorial. One, it's an identification issue. Trying to identify when mental health is a problem, trying to hook the person up with the right care, and having the person stay in care, and having that relationship to continue, and getting them on getting people on the right therapies. So I think that just like the HIV cascade, and I showed you that fracture cascade, there's a mental health cascade as well. And I think we have a lot of people who a lot of people say with depression who haven't been identified as having that. And so I think identification is really important. And so identification should happen. This is another, something that sort of would be a great adjunct to a regular visit, with depression screening, to try to, we talked about physical function screening, but depression screening would also be very helpful if we could do a quick screener at a regular primary care visit for depression, and then refer that person appropriately.
I'm interested if there are theories about the directionality of the depression, such as a cognitive decline correlation.
Yeah, and in reality, the arrow goes both ways, and so that's what makes this really difficult to sort of understand, and to intervene on, is that depression can lead to cognitive troubles, and then cognitive troubles can lead to depression, and you get into this spiral, and sort of an accelerated kind of thing. And the more depression you have, the more it affects cognition, and the more cognitive decline you have, the more it affects depression. And so I think breaking those kinds of spirals is really important. So I think that's it's an important question, which way the arrow goes, and the question is, and I think the answer is, it goes both ways.
Let me search for this question. Okay, great. It's clear we need HIV clinics that provide comprehensive, multidisciplinary, whole person care. How do we make that a reality? There's a pilot program at UMMS in Baltimore, but nothing for the rest of the state. Nothing in DC or Northern Virginia. How do we change that?
Yeah, I think we need, I think at a institution, you need a champion to do that. You need someone to say, okay, I'm going to start a clinic for older. I'm a geriatrician. I'm going to start a clinic for older people with HIV, and then they carry that flag. Ideally, it would be incentivized by, and generally, states run their own Medicare programs. It would be incentivized by the state, and there'd be some, perhaps some reason why a person would want to do this. Part of it is, academics and trying to figure out what your niche is going to be in academia, trying to do something good for a group of under served people. There's definitely a need for it, but trying to incentivize making those clinics, through the state Medicare programs, I think is important.
Is there any new research on neuropathy? None of the pain meds worked without clouding my mind. Is there anything being done to either repair the nerve damage or effectively treat the pain? I'm not sure which is worse, the numbness or the pain, but I can't find anything new because I've tried everything and it hasn't worked. It impairs my mobility and quality of life.
Yeah, neuropathy is a real problem, and yeah, I unfortunately, once the neuropathy starts, we can, say diabetic related neuropathy, we can try to slow the progression, but there's not much we can do to reverse it, and so that's concerning. So I'm not sure what this person's been on. Sometimes it takes multiple agents to be effective. Other adjunctive therapies may be helpful. Things like acupuncture may be helpful if that hasn't been tried, or medical marijuana can be helpful for neuropathy. But I agree, it's a very difficult problem.
I did miss a question. It's more about representation and data. Creative included awards targeted to those POC groups that were mentioned.
I'm sorry, I missed that question.
This question is in regards to representation, maybe in some data that you showed during your presentation.
Okay.
It's maybe discussing why Native Americans weren't showed in the study. And with, yeah.
Yeah, I mean, I think that the issues have to do, obviously we want to know, in various ethnic and racial groups, if there are differences, whether it be associations or treatment exposure, et cetera. Generally in these populations, Native Americans it's just too small of a group. And sort of if they identify as Native Americans, they're sometimes grouped into a sort of an other type group. I think a larger population, if we're a larger population where you could make finer distinctions and make more meaningful groups, I think that would be the way to go.
Right. And that is the rest of the questions.
Okay.
I will give it a couple more seconds to see if anyone else has any questions that they can put in the question box. Okay, great. We just got one. Is growth hormone deficiency a factor for HIV long-term survivors? And is replacing growth hormone in someone who is deficient recommended?
Yeah, so that's a good question. Growth hormone deficiency is, it's a recognized issue, particularly people who have pituitary problems. Growth hormone is one of the hormones that the pituitary makes. There's some evidence that the growth hormone axis may be abnormal in people with HIV, particularly those who have lipodystrophy, so central fat accumulation, peripheral fat wasting, and there's an analog to a growth hormone releasing hormone that's available to decrease visceral fat among people with HIV, called tesamorelin. But unless there's some reason why you suspect that someone has growth hormone deficiency, so that they've had, say, pituitary surgery or injury to the pituitary, it's generally something that's not explored readily in and of itself. And there's as far as treatment goes, there's good treatment for good data, at least some data on using tesamorelin to decrease visceral fat. We'd like longer term data, but decent short term data. There's data for growth hormone replacement for someone who has a pituitary problem, but really not for the run-of-the-mill person who you test and has has growth hormone deficiency.
All right. Another question we have is it true that people with HIV engage in more harmful behaviors than people without HIV?
Well, it sort of depends. There's a lot of qualifiers there. Which harmful behaviors and which population of people with HIV and which population of people without HIV. And so I think in general, smoking rates are pretty high. If we're talking about comparisons to the general population, smoking rates and drug use are relatively high in populations with HIV. So I think that there's definitely room for improvement there. So those are the two big, smoking and drug use, I think are the ones that have been most studied.
Thank you. Another one we have is, once screened for mental health, do you think we have enough providers for the demand? You said Johns Hopkins has no services currently, mental health services.
Well, yeah. So I didn't mean to say that they have no mental health services, but it's it's not easy to get an appointment, and you can get an appointment, and one we have just like I'm the endocrine guy in our clinic, we have psychiatrists. So if I have an issue with one of my patients with HIV, and they really need to see a psychiatrist for their depression, I call the psychiatrist who is connected to the HIV clinic. And that's another way to sort of grease the wheels, is to have specialists that are part of the HIV clinic. And that way providers have someone to call and someone to facilitate these kinds of referrals to mental health services.
Thank you. Another question we have is, where are active duty military and veterans fit into this research?
That's a good question. I don't think we necessarily ask. I mean, I don't know of any. There was, or I'm not sure if there still is, a cohort of people with HIV in active duty. There is the VA does quite a bit of research in HIV and aging, and trying to understand. So these wouldn't necessarily be active duty folks, but they're definitely military folks. But I think it's an important population to study, no question.
Great. Because of the difference between biological and chronological age, would you advocate for resources assigned via chronological age be done or via biological age?
Yeah, that's a good question. Right now, it's more theoretical than practical, because no one has a measure of biologic age that is completely reliable. There's some questions. There's some things that have been proposed, and I mentioned the epigenetic age, but right now it's sort of at the stage of research and trying to figure out how it potentially could be used clinically, rather than something that can be implemented in the clinic. But you can imagine, yeah, so that if you could measure reliably someone's biologic age, then you would want to sort of intervene earlier, particularly if there's a big discrepancy between their biologic age and chronologic age, such that their biologic age is certain amount, 5 years more than their chronologic age, or the change in their biologic age is going faster than their chronologic age. And so, yeah, I think it's a really interesting question. I think we're not quite there yet in implementing it in the clinic.
Okay. Is tesamorelin not recommended for people with type 2 diabetes?
Yeah, so tesamorelin is that growth hormone releasing hormone analog that I mentioned. You can use it in people with diabetes. Personally, I want people to be better controlled in their diabetes than before they start, and because it can slightly, at least in the trials, make the hemoglobin A1C, that 3-month measure of blood sugar control, increase a little bit by about 0.2. And so I like to have people better controlled before they start on it.
And this is our final question. If we provided online screening for specific issues such as mental health using validated tools, how would PCPs and HIV specialists react to patients who came in with their results for discussion?
I think positively. I mean, I think that getting that information and empowering patients to get that information, I think is really important, and I think that they'd be all ears.
Thank you, and Moises, I'll have you close us out.
All right. All right. Thank you, everybody, for your participation. Usually, I love to see when there is a lot of questions, that tell you the presentation really did what it was supposed to do. So thank you to Dr. Brown again for your generosity with your knowledge and your time. And I think if people have other questions, they can email them to us. And between Jules and myself, we can figure out a way to get them answered. And then also we may distribute the link to the recording of this session.
Sure.
If you need to watch it again, if you have colleagues that you want to share it with, I think it would be very beneficial. So with that, I wish Dr. Brown and everybody else a good weekend, and until the next time. Thank you.
Great. Thanks.